Welcome to All in All.
Great to be diving into this.
Yeah, definitely. If you're a dialysis RN or maybe a tech and you're, looking to solidify your knowledge or even aiming for that RN spot in a clinic.
This is for you.
Exactly. We've got a whole bunch of materials here, policies, research bits, guidelines,
Kind of a cross-section of what's out there.
and we're going to unpack them together. The goal really is to dig into the different dialysis types.
Pull out those key insights.
Right. And have a good chat about it. Collegial, academic, hopefully really useful so you feel well informed for your practice.
Starting broad and then getting into the clinical details. Sounds like a plan.
Okay, so let's start unpacking. Dialysis, at its heart, it's renal replacement therapy, right?
Absolutely. When the kidneys fail, it steps in to clear waste, remove excess fluid.
And the sources we looked at mainly focus on the two big ones, hemodialysis, HD.
And peritoneal dialysis, PD.
Yeah. And it seems a key point right off the bat is that both can be equally good options.
That's crucial. It's not about one being definitively better overall. It really comes down to the individual patient. Their medical situation, sure, but also their lifestyle, their preferences.
It's very patient-centered.
Exactly.
Okay, so let's dive into hemodialysis first. HD, this is the one where blood comes outside the body for filtering.
Right, extracorporeal. And the core component is the dialyzer, the artificial kidney.
That cylinder with all the tiny fibers inside.
Yeah, thousands of hollow fibers. They act as the semi-permeable membrane. Blood goes through the fibers.
And the dialysate fluid flows around them.
Precisely. That interface is where the magic happens. Diffusion of waste out, ultrafiltration of fluid.
And that dialysate, it's a sterile solution, carefully mixed.
With mineral ions designed to create that concentration gradient, pulling waste like urea, creatinine, potassium, phosphate out of the blood.
The sources mentioned sodium and chloride are kept pretty close to normal plasma levels.
Generally, yeah. And buffers like bicarbonate or lactate are added too for pH balance.
But the sodium level in the dialysate, that seems to be a bit of a hot topic.
Oh, definitely. It's quite controversial, actually. The sources touch on this debate about the optimal level and its link to outcomes.
Like higher sodium might make patients thirstier, gain more fluid between treatments?
That's the concern, yeah. But then lower sodium dialysate, well, that's potentially linked to more muscle cramps, maybe more intradialytic hypotension.
So drops in blood pressure during treatment.
Exactly. And some studies even suggest a possible link between lower sodium and mortality risk, though it's complex and still debated. Finding that sweet spot is tricky.
Right, not a simple dial setting. And the membranes themselves in the dialyzer.
They've evolved. Used to be mostly cellulose. Now, often modified cellulose or synthetic materials. And they come in different types, mainly low flux or high flux.
Based on pore size, essentially.
Yeah, how big the holes are. It matters for clearing different size molecules. Both clear small stuff like urea well.
The bigger molecules.
Like beta-2 microglobulin, that's where high flux comes in. Low flux membranes don't clear it well.
And that buildup over years can cause problems.
It can. Things like amyloidosis, leading to carpal tunnel, bone cysts. The sources suggest high-flux membranes or even techniques like online hemodiafiltration or IHDF.
Which adds convection to diffusion.
Right. They might help clear more of those larger molecules, potentially reducing those long-term complications.
Okay, let's talk about what you might see during a treatment. Common complications. Intradialytic hypotension IDH seems pretty high on the list.
It really is. The figures mentioned are around 25–30% of treatments, which is significant.
And it's linked to fluid removal rate, affecting blood flow back to the heart.
Often, yes. It can be worse in patients who already have heart issues, like CHF or LVH.
So managing it involves careful fluid assessment, getting that dry weight right.
Absolutely. And looking at their blood pressure meds, the sources specifically mention avoiding short-acting ones right before dialysis if possible.
And sometimes other things are used, like hypertonic saline.
Yeah, osmotic agents like hypertonic saline, D50, mannitol, sometimes albumin are mentioned as considerations to help pull fluid back into the vessels, but prevention is always the goal.
Then there are muscle cramps, another frequent complaint.
Very common. Hands, legs, feet usually.
Yeah.
The causes aren't always crystal clear. Could be tissue hypoxia from fluid shifts, maybe removing volume too fast.
Or the dialysate sodium, like we mentioned. Or maybe their dry weight isn't quite right.
All possibilities. Basic stuff like massage, stretching, heat or cold packs often helps first.
And dialysis disequilibrium syndrome, DDS. That sounds more serious.
It can be. The theory described relates it to solutes, mainly urea, being cleared from the blood much faster than they can cross the blood-brain barrier.
So the blood gets cleaned faster than the brain tissue.
Essentially, yeah. Creates a temporary osmotic gradient, water shifts into brain cells, causing potential swelling or edema.
Leading to symptoms like headache, nausea,
Yeah.
or worse.
In severe cases, yeah, confusion, seizures, even coma. It's why you're cautious with initial treatments or very high BUN levels. You don't want to be too aggressive initially.
Makes sense. Beyond those, there are the real emergencies you have to be ready for. Air embolism.
A critical one. You might actually see air or foam in the lines, or the venous blood.
Or the patient suddenly gets chest pain, trouble breathing.
Maybe a churning sound over the heart, or sudden neurological changes. Action has to be immediate.
Stop the pump.
Instantly. Clamp the lines, both arterial and venous.
And crucially, don't return the blood.
Absolutely not. Then get the patient positioned left side, head down. Trendelenburg.
To try and trap the air.
Trap it in the right ventricle, keep it away from the pulmonary circulation.
Okay. Another scary one. Blood in the dialysate, a blood leak.
Right. If that dialysate tests positive with a chem strip, or you actually see pink or red.
Same principle, stop. Clamp lines, don't return blood.
Exactly. Contact the MD or NP immediately. Monitor the patient closely. And that machine needs special disinfection before reuse.
All these risks really highlight how vital the dialysis prescription is.
Hugely important.
Right.
And a key part of that is nailing down the patient's dry weight.
Which the sources define as what? The lowest weight they tolerate post-dialysis without signs of being too dry or too red.
That's the concept. Minimal signs of hypo or hypervolemia. But the material is pretty clear just looking at, say, ankle swelling or listening to the chest.
Isn't always reliable for judging fluid status.
Surprisingly unreliable sometimes. It's a real clinical challenge to accurately assess and achieve that target dry weight consistently.
But getting better at it along with other advances seems linked to better outcomes over time.
The sources suggest so, yeah. Better dry weight management, better treatment of heart disease, vaccinations. It all plays a role in the declining death rates seen over decades. It's complex, but fluid management is a massive piece.
And thinking about your role, as RNs and techs,
Yeah.
the sources mention common areas for citations.
Yeah, things that regulators focus on. Infection control is always big.
Patient assessment, too, and following the plan of care meticulously.
Absolutely. And to combat those issues, the sources really emphasize education for staff and patients, plus solid documentation and clear communication.
Calling them the most important tools.
Pretty much. For making sure orders are followed and patients are safe.
Okay, let's switch gears. Peritoneal dialysis, PD.
Right. This uses the patient's own body.
The peritoneal membrane inside the abdomen acts as the filter.
Exactly. A catheter is placed into the peritoneal cavity. You instill dialysate fluid, let it sit there, that's the dwell.
And then drain it out, taking waste with it.
Correct. And it can be done manually.
With gravity, using bags.
Or using a machine, automated PD or APD, often done overnight while sleeping, like with CCPD, continuous cycling peritoneal dialysis.
Big advantages mentioned are flexibility, right? Doing it at home.
Huge advantage for many. Much more freedom, fits into life better potentially, less disruption than traveling to a center multiple times a week, can help maintain that sense of a normal life.
And maybe less strain on the heart and blood vessels compared to HD.
Generally considered gentler in that respect, yes. Some studies referenced even suggest possible benefits for longevity and quality of life for some patients.
But PD has its own risks. Infection seems like a major focus in the sources.
It is. Peritonitis is the big one. Inflammation of that peritoneal membrane.
Usually from bacteria getting in?
Most often, yeah. And touch contamination during the exchange process is a really common way for that to happen. About 80% are bacterial.
What are the warning signs you look for?
Classic triad: fever, abdominal pain, and cloudy effluent. The drain fluid looks milky or hazy.
And a key lab test.
Checking the white blood cell count in that effluent. A count over 100 is a strong indicator mentioned in the guidelines.
And management involves?
Getting cultures of the fluid, identifying the bug, and starting antibiotics quickly, often empirically at first, based on likely culprits.
But sometimes the catheter has to come out.
Yes, that's a critical point discussed. If the peritonitis is refractory, doesn't clear up or keeps coming back, or if it's fungal, or caused by certain gut bacteria, or mycobacteria, removing the catheter might be needed to save the peritoneum itself from permanent damage.
Common bacteria mentioned were Staph aureus and coag-negative staph.
Yep, those are frequent offenders.
Besides peritonitis, what about the catheter site itself?
Exit site infections are also a concern. You're looking for redness, swelling, pain, any drainage right where the catheter comes out of the skin.
And tunnel infections.
That's when the infection tracks along the path of the catheter under the skin. Treatment depends on how deep it goes, sometimes requiring antibiotics, sometimes catheter removal.
Okay, other potential hiccups with PD, like trouble filling or draining.
Yeah, that happens. First steps are simple check for clamps being closed, kinks in the tubing.
Could be fibrin, those whitish strands.
It could. Fibrin is a protein that can sometimes form little clots or strands in the fluid and block the catheter holes.
What helps then? Changing position. Coughing.
Those can sometimes help dislodge things. Making sure the fill bag is high enough, drain bag low enough.
And if fibrin is persistent...
The sources mentioned possibly adding a bit of heparin to the dialysate bags to prevent more clots forming.
What about leaking fluid?
Can happen, especially early on, or if intra-abdominal pressure is high. Needs assessment.
And pinkish fluid, is that always bad?
Not necessarily. Often just a tiny bit of blood, maybe around a period for women, or after heavy lifting. Usually clears up. Just needs watching unless it's significant or ongoing.
And there are metabolic things too, like weight gain.
Yes, because the dialysate contains glucose, which gets absorbed. Adds quite a few calories. So hypertriglyceridemia and potential weight gain or obesity are things to monitor and manage with diet.
So for PD care, the focus is really on
making sure the patient understands everything, assessing their ability and support at home, tons of education on sterile technique for exchanges, and catheter care.
infection control is paramount.
Absolutely. And ongoing monitoring for any of these complications, plus checking that they're getting enough dialysis that it's adequate.
So stepping back again, HD versus PD, both work.
Both are effective renal replacement therapies. The choice, like we said, comes down to medical factors and what fits the patient's life.
Involving them and their family is key.
Crucial. Supporting that goal of living as normally as possible with a chronic illness.
Now, thinking about infection risk again, comparing the two, the sources had an interesting point about home therapies.
Right. Generally, doing dialysis at home, whether it's home HD or PD, might lower the risk of healthcare-associated infections just by avoiding frequent clinic visits.
Makes sense. But then comparing home HD versus PD.
There was a study discussed that found actually patients on PD, both CAPD and APD, had a higher risk of severe infections needing hospitalization compared to patients doing home HD.
And that difference was mostly due to
Peritonitis. It's just much more common in PD than bloodstream infections are in home HD patients. So even though both are home therapies, the type and frequency of infection risk differ significantly.
So hospitalization rates for severe infections were higher for the PD group in that comparison.
That's what the data suggested. It really highlights why that meticulous infection prevention for PD is so incredibly vital.
Absolutely. So bringing this all back home for you, the listener, understanding these nuances between HD and PD.
The procedures, what can go wrong, the signs to watch for.
It's all fundamental for providing great, safe care, especially if you're stepping into an RN role with more assessment and decision-making.
Yeah, your role isn't just technical tasks. It's that vigilant assessment, noticing subtle changes. It's patient education.
Right.
Remember how the sources called that a key tool?
Right, and communication. Talking with the patient, the family, the team, managing issues, supporting them.
It's a huge part of it.
So thinking about that infection data, the higher peritonitis rate in PD compared to bloodstream infections in home HD. Here's something to chew on.
What are the absolute most critical things that you, interacting with patients day in and day out, can directly influence to minimize infection risks? Not just in one modality, but across the board. HD, PD, in-center, home.
That's a great question to reflect on. What's within your direct control every single shift?
Definitely something to consider.
Good food for thought. Thanks for listening to All and All.